Good morning, everyone. My name is Arditya, and I represent Clinical CPMC Brunei and Universitas Gadjah Mada Indonesia. So let's explore the complexities of aorto-ostial interventions. These procedures pose significant challenges due to various factors such as high calcium content, fibrous plaque, and elastic recoil, and technical issues like catheter engagement and anatomic variations make this kind of interventions is difficult. Additionally, incomplete lesion coverage or stent protrusion is not uncommon and associated with adverse cardiovascular events. So, despite advancement of the technologies and techniques such as intracoronary imaging, the clinical outcomes of the aorto-ostial intervention is improving, but the protruding stents itself, especially those in place for extended periods, like in more than few years, remain understudied. So this presentation or this case will explore a case highlighting the complexities and implications of aorto-ostial interventions. Before we explore into the specific case, let me provide you some background information. The patient is 54 years old man with hypertension, diabetic hyperlipidemia, normal LVEF, and having positive SSS tests. And a decade earlier, these patients underwent extensive stenting of the right coronary artery following NSTEMI and followed by stage left main LAD circumflex artery cylinder PCI in the same year and underwent ostial circumflex PCI 3 years later. So for now, patients underwent angiography with results like this. We appreciated wide in-stent patterns and the bifurcations left main LAD and circumflex, moderate ISR and moderate native distal LAD disease, no significant ISR of ostial circ or large OM, severe focal stenosis of the distal OM. And in the RCA here, we might see that the RCA is standard. RCA standard from ostium distal vessel and showed mid vessel and ostial ISR. So at this stage, we performed the PCI to RCA. We used 6 French GR4 catheter, ensuring smooth wire progression, and we performed the IVIS in the coronary imaging, and it showed the MSA in the mid ISR is 3.7 millimeter square, and we appreciated a pressure damping and the ostial RCA. Subsequently, we proceeded to PCI to address the ISR there with a 30 millimeter cutting balloon in the mid proximal to the ostial. And at this stage, when we performed stent enhancement or the stent boost, we appreciated that was a stent protrusions there on the aorto-ostial of the RCA. So in this time, we discussed with the other intervention cardiologists and the team, and we decided to stop this procedure for now because of the concerns of the stent fracture due to embolizations. Then we performed CTCA to the patients, and there we can appreciate that revealing a 9.1 millimeter of the stent protrusions to the ostial RCA, which fortunately did not touch the aortic valve, as we can see in the most right picture there. So after this, 2 months later, patient come back because of the complaint of the chest pain. But at this time, we decided to perform the PCI to resolve the problem on the ostial only, because we decided to leave the mid RCA because we already performed the cutting balloon in the previous procedure. So in this procedure, we used IVIS-guided PCI and plan to manage the stent protrusion effectively while minimizing risk. So based on the IVIS, the ostial showed the MSA is around 6.9 millimeter square, and because we already understood that there was a protrusion stent on the aorto-ostial, so we put the catheter there and the wire and the devices through the side of the stirred stent that is protruded. Afterwards, we perform ballooning to the proximal ostial vessel with 4.5 non-compliance balloons, and we perform PCI, deploy a 4.515 drug-eluting stent in the ostial proximal RCA with the technique called bumper wire to ensure that the deployment of the stent is not protruding like the previous procedures. And we performed ostialate with a 4.5 NC balloon to ensure that the ostial part of the new stent is sufficient enough to make the vessel bigger. Then the final picture showed like this. We also perform stent enhancement to see that still there is a protrusion, but it will not affect the ostial of the new stent. And when we perform the IVS, it showed that the area is 17.1 millimeter square compared to 6.9 millimeter square, or we perform the PCI to the ostial. There. So for the discussion itself, let's discuss about the further implications of the aorto-ostial lesions and protruding stent. So the incidence of aorto-ostial lesions is higher than the left coronary artery, and it underscores the importance of understanding the characteristic and to address the challenges that we might find when we perform the aorto-ostial lesions. So the problem is getting worse because the anatomic variation in the RCA and also the limitations of the angiography. So the incomplete coverage or excessive stent protrusions termed geographical miss associated with adverse cardiovascular events and the risk of stent slippage and complications post-stenting, including neointimal hyperplasia and external oppositions, can also be the problem when we perform the aorto-ostial lesions. So how about the stent protrusions and how to avoid it? So the importance of stent deployment at coronary ostial region, we have to balance the coverage and avoidance of overhang, crucial for successful deployment. Based on the literature, the recommendations of maximum stent protrusions is around 1 millimeter range to prevent complication in the future stage of the patients. And incomplete coverage, called geographical miss, will increase the risk of ISR, and while excessive protrusions poses thrombosis and aortic valve trauma risk. And also the mechanism linking stent protrusion and thrombosis, we already aware that the protruding stent disrupts blood flow, increasing stress and also increasing the activations of the platelet. Furthermore, incomplete stent coverage contributes to late stent thrombosis and exacerbating over time. And in these patients, the previous PCI was around 10 years, but fortunately, there was no significant complication like thrombosis or in-stent restenosis, although we might see in the first procedures that the ostial pressure damping, but fortunately, we can tackle the problem with the specific technique and devices. Furthermore, neointimal breach formations further compromises blood flow and exacerbates thrombotic event. And third, efficacy of interventions techniques and management strategies is important. And like what we perform in these patients, we perform bumper wire or some literature called double wire or floating wire, and it's proven effective in aorto-ostial interventions. It also reduces geographical miss if we use IVS, like in this case, and give favorable clinical outcomes observed. And management strategies include expansions of proximal stent struts using fast ostial balloon or a stent flaring through repeat blood infusion could also be performed. And how to manage in ISR in an overhanging stent, like in this case. So the challenges in the interventions in protruding stent is the problem of catheter engagement, coaxial alignment, and also stent wiring difficulties. And by using the side struts of the stent, the overhanging stent, like what we found, is also a good technique and also a good thing to do because it's quite impossible to perform PCI through the ostial of the stent, the overhanging stent there. But also it will give the risk of stent deformations, dislocations, or embolism and obstruction due to stent overhang there. And steep angulation and rigid metallic obstacles might hinder device advancement. And alternative techniques for excessive stent overhang also include double wire insertions, balloon-assisted procedures, snare devices, and catheter extension-assisted stenting. And second, ballooning of set roots can also be effective in addressing overhang challenges. Lastly, for the case outcome and intervention strategies, we already observed that the favorable outcome over 10 years without thrombosis observers are found in this case, and utilization of more wire technique and side-strut second balloon technique in the interventions was successful in this patient, and improved stent expansion and malposition resolution confirmed by IVIS post-PCI. In conclusion, so we have to know that accurate stent placement and protrusion is important because it's crucial for optimal ostial coverage and minimize stent protrusion to prevent complications. Second, deformation and intervention techniques is also important because we already know that prior interventions may lead to stent deformations, and also IVIS-guided techniques facilitate precision interventions. And lastly, the implications in adaptability in this case, because we can learn from cases and inform future interventions, and also emphasizes the need for tailored approach and true assessment. Thank you.